Hello, everyone, and welcome to the next edition of the Academy by Acclivity Health Solutions. My name is Jeremy Powell. I'm one of our founders and the CEO. Today's Academy session is coming to us as a suggestion from one of our users of the Academy who wanted to learn a little bit more about primary care first. If you're new to the Academy, it is an opportunity for us as the leaders around the value-based care space to educate the market about models within primary care. First, as an example, within CMMI, within ACOs or alternative payment models, to educate the market about how they work, how to use them to garner success, whether it's revenue or clinical outcomes. And the question came in for us to do a session on primary care first. It's a fairly substantial program. It builds on the back of Comprehensive Primary Care Plus, and before that, Comprehensive Primary Care. It's a model that pays a capitation payment for the number of patients assigned to the model at the practice level. So by risk, your lowest risk patients, or by practice, the lower risk average practices get paid $28 per member per month in capitation plus visit fees. The highest risk, which is level 4 in that program, pays $175 PM plus visit fees. So it's fairly substantial, especially if you're coding the patient risk appropriately and you are taking care of, largely the sicker the population you care for, the more you make in capitation. So it's a model created by Medicare under the CMMI, the Centers for Medicare and Medicaid Innovation organization. It is an organization program from that innovation arm that really attempts to take some of the ACO, the best practices of an ACO, Medicare Shared Savings ACO specifically, and bring it down to the individual practice level without requiring a whole list of governance. You don't have to have the public reporting components of ACOs. You don't have to carry a lot of that other incumbent difficulties or barriers to entry. So it's an ACO, so to speak, but at the practice level. So things that often people will ask, well, how do I succeed when I don't have that infrastructure the ACO provides, like governance and actuarial science expertise or population health management, modeling. So we would suggest you find access to those kind of resources and actuarial science resources, healthcare economist resources. We would think that the kind of thing you'd want to do is understand how to process CCLFs. There are a whole host of population health tooling. That particular model, Primary Care First, has this concept of leakage or payment adjustments. If you're not seeing your patients for primary care related care, those dollars come out of capitation payments. So you want to make sure you wrap your arms around your population attributed to the model and you don't have journeys happening outside of your purview. You want to focus, especially as patients, sort of trend up in the advanced illness or sort of journey through their, last corridors of life. You want to think about how do I document and deliver care for them? And then you want to always, in all models, think about how do I react to things that are happening in the highest cost, locations of care. So think about emergency notification, so you can build, models around ED diversion and inpatient utilization, like training up your staff and then training up those patients that they see to understand better where and how to access care. So similar to an ACO, these are the kind of building blocks that might be used for an ACO. When we break them down and distill them into what does it really mean? CCLF files, those are the claims and claim line fee detail, in essence, adjudicated paid claims from Medicare that are available in the ACO world and in Primary Care First and many other models. So you need to be able to very clearly take those details into a system and then be able to process them, build your analytics and risk stratification and manage, care management models on top of them. In a program like Primary Care First, where leakage is measured as a reduction in capitation, it's a first order thing you've got to do. You've got to understand, are you having churn that you can't actually sort of impact, which is going to potentially have you be helped or not helped in the models that you're participating in? Are multiple primary care practices serving this? Do you have multiple primary care practices where internal leakage might just happen that they go to a different practice and see someone who's potentially aligned to your organization, but not aligned to the primary care first location of care? Therefore, that looks like internal leakage. Like, these are the kinds of things that reading those CCLF files with tooling will help you understand, because you really can fix simple things and drive out that leakage and therefore improve significantly your revenue associated with the program. You'll also need to be able to think of it not just at the individual location, but also specifically down to the individual provider, so they can react to the fact that some of the patients they're caring for quite regularly are still somehow getting seen by other parts of the community where primary care related services are being applied. Again, it could be a taxonomy issue. It could be in your same practice, but they're going to another location and therefore not aligned appropriately to the right kind of care for you to get the right kind of attribution. There's good and bad, sort of leakage. Internal leakage is the good leakage because you might be paid fee for service versus capitation. So they're making those adjustments. Well, a tool like this would help you decide, is that something you chase, or do you have higher priorities in the leakage detail that you actually need to, circle around your resources to do other work. You'll also need to think about, as you could imagine, when patients really move through, their journey to and towards the end of life, what happens to frailty, disease burden, acuity, what are the needs you need to address? So when you take in that raw claims data, you have the ability to, stack patients into literally appropriateness based upon the kinds of services that would be best rendered to them. Those are only made available when you have the entire history of this person's journey through all locations and all types of care. So being able to do sort of an advanced illness reporting or workflow would be super helpful. Taking those raw patient claims detail that you get, from Medicare and then distilling down into face sheets are very typical for how that kind of technology can support point of care decision making. So you can see things like alerts, you can see things like coding opportunity, because the more you code up, the potential you have to move from level 1 to level 2, level 2 to level 3. And with each jump, it's a significant jump in capitation. So $28 to $45, $45 to $100, $100 to $175 per patient per month. Those are big jumps from a revenue perspective. So be mindful using a tool to support your advancement of your models of care, and what your point of care clinicians know will become vastly important in your workflows. And then, as we mentioned, knowing in real time when there's an admission discharge transfer notice allows you to really impact care through marrying those claims data that are available to you in a model like this with usually free or low-cost solutions that can tell you real time what's happening in your population across all of the high-cost sites of service, emergency departments, acute facilities, and post-acute facilities. These are the kinds of things that become really helpful in a model like Primary Care First. Thank you guys for making the suggestion. If you want me to dive deep into other parts of Primary Care First, if you want to talk the capitation and reimbursement, or any of the fees that are covered under that arrangement, what they mean, I'm happy to dig deeper into that with you all. Really trying to make sure that there's an opportunity for you guys to ask these questions. If you have questions or want to ask more about Primary Care First or other models, or any of the other topics that you'd like for us to bring to the Academy, please send us an email at info@acclivityhealth.com. Thank you much. Talk soon.